we move to the final section of Lecture 1, which is the use of other important cardiac drugs, just so you understand them or you've seen them once. So digitalis, we touched on that. It was discovered in the foxglove shrub, so it's actually a plant-derived substance that then gets made synthetically into digitalis, a cardiac glycoside that's been, dates back hundreds of years, back to 1785. It's been used for congestive heart failure and a number of things. As I talked to you about earlier, it inhibits the sodium-potassium ATPase, an enzyme that drives the sodium-calcium exchanger. So it's going to block calcium from being pumped back from the heart muscle out into the extracellular space. I'm going to keep more calcium inside the heart muscle. More calcium means I'm going to unlock more troponin and cross-bridge. I'm going to have myofilaments that are going to be contracting more. I'm going to increase the force of contraction of the heart. I'm going to have an inotropic effect on the heart. I'm increasing the force of contraction by trapping more calcium inside by inhibiting that particular calcium-sodium exchanger pump. So that'd be useful in congestive heart failure where the heart pump is weak, and in other cardiomyopathies where the heart is struggling to beat, they give the person digitalis. And so this slide just sort of reviews how the calcium-sodium exchanger pump works. You can sort of read that on your own time. These are the other effects. These digitalis type drugs are also decrease the vagal effect on the heart, or it increases the vagal effect, so it can slow the heart rate down and decrease atrial fibrillation. So it can also help with respect to what are called reentrant arrhythmias. So in a reentrant arrhythmia, you have this constant circuit of hyperirritability of certain muscle cells, and it's creating an arrhythmia. And so by giving the person digitalis, you can sort of tone that down and decrease the likelihood of atrial flutter and paroxysmal supraventricular tachycardia and other types of dangerous ventricular tachycardia. So digitalis can also be used because of its effect of increasing the vagus system and the parasympathetic system in treating these reentrant arrhythmias. But if the person is in a very high sympathetic state due to a really acute illness, it'll override the effect of the drug. Or if the person is exercising, the sympathetic effect will override the effect of the drug, and the arrhythmia may come back. So the clinical applications for digitalis are heart failure, especially when there's atrial fibrillation. And it's often prescribed for patients with atrial fibrillation, especially if they've been diagnosed with heart failure. So often when these things are concurrent, digitalis is the drug of choice. These are the side effects, though. Because it has the vagal effect, if the person is at risk for heart block, it can cause a sudden death from a heart block effect, or it can have a rebound effect creating tachycardia. The thing about digitalis that's so worrisome, it has a very narrow therapeutic index of safety. That means that the dosage has to be exactly right, or you put the person into a cardiac event. So I don't know if you remember this, maybe you're too young, but just a number of years ago at Sick Kids Hospital in Toronto, there was a nurse who was accused of actually creating homicides in some of the children in the cardiac ward by deliberately giving them higher doses of digitalis. Some of those children died, big court case. It was in the papers for a very long time. I can't remember the outcome exactly. But digitalis is a very tricky drug. And because it's tricky, you have to make sure you don't give supplements to a person that's on digitalis that are going to amplify the effects or increase its detoxification. So Hawthorn amplifies the effects of digitalis. Can't use Hawthorn with digitalis. Got to be an exam question. Also, ginseng has been shown to sometimes enhance the effect of digitalis, sometimes have the opposite effect, tone it down. Either way, Hawthorn and ginseng are not options for people taking digitalis. Another drug of interest that you'll see people on, especially if they have angina, of course, is nitroglycerin. What do nitroglycerin drugs do? They're going to increase the amount of nitric oxide in the blood vessel wall. That's going to cause vasodilation. But nitroglycerin primarily causes vasodilation of the veins, not the arteries. So the amount of blood flowing back to the heart, the preload effect on the heart is going to be less. So now that the heart doesn't have to pump as hard because there's less blood filling the chambers, so there's less oxygen demand by the myocardium, the heart doesn't have to pump so hard, so the angina is controlled. So a person starts to have an angina attack, they might use some sublingual nitroglycerin in that moment just to settle the attack down. Dilates blood vessels, including the coronary vessels, and it decreases the preload effect on the heart, subsiding all these things like chest pain, blood pressure, increased heart rate, and so on. So it's administered, there's different ways from tablets to ointments to intravenous use, transdermal patches and sprays that can be used sublingually. Adverse side effects, lack of sexual desire, headaches, it's just like, if you ate a really cold ice cream cone and you get that sort of, So if all your blood vessels dilate all at once, you can also get a similar kind of headache that you would get from eating, a Freezy or a Slurpee or something like that. You ever have something like that? You suck it up in the straw and go, brain freeze, painful urination, increased bowel movements. All right. So this leads us into some of the natural things. And last year I talked to you about coenzyme Q10, so I'll keep this short for you. Excuse me. So in terms of the complementary management of congestive heart failure and arrhythmias, you know that CoQ10 is this vitamin-like substance that the body normally makes. It looks a lot like vitamin K. What CoQ10 is doing, of course, in the mitochondria, it's shuttling the electrons down the electron transfer chain so that the cell can make more ATP energy. So if, as you get older, because you may have less CoQ10, you can't make energy at the same rate, and this has an effect, we think, on increasing risk of congestive heart failure. The heart muscle gets a little weaker. It doesn't have as much ATP. There's a bit of a power shortage, if you will, in the muscles. There is the chemical structure of CoQ10. It looks a lot like vitamin K. I bring that to your attention because if a person's on a drug that inhibits the effects of vitamin K, and we're going to see these drugs like coumarin or warfarin, if you give coenzyme Q10, you may counteract the effect of the drug. And so CoQ10, when given with coumarin or warfarin, the person has to be monitored to make sure that the blood clotting effect stays in the range that the doctor was suggesting. So the INR has to be monitored. We're going to see that. So CoQ10 is a vitamin-like substance present in all human cells. 95% of all the energy you're making in your cells right now is being made aerobically. About 5% is being made anaerobically. When you're just at rest or light to moderate activity, 95% of the energy in all your cells, including your brain cells, that ATP energy that you're generating to power your biological machinery, primarily through aerobic pathways to mitochondria, CoQ10 is intimately involved in that. Therefore, organs with the highest energy requirements, such as the heart, the lungs, the liver, have the highest CoQ10 concentrations because there's a lot of metabolic activity there. They've got to generate a lot of ATP. There's high levels of CoQ10 there. If those levels drop in the aging process because you don't make CoQ10 at ideal levels, then these tissues become affected. This is just showing in the mitochondria that CoQ10 is required to actually transfer hydrogen electrons from the first cytochrome to the second cytochrome. So if it's not there anymore, it's like there's a piston missing in the engine. You can't make as much ATP with aging. So CoQ10 deficiency is associated with congestive heart failure. The heart pump gets weaker. Increased blood pressure because you can't release as much nitric oxide and other effects. It aggravates angina and arrhythmias. We know that because in people that have angina and arrhythmias, sometimes giving them CoQ10 makes it so they can take lower doses of their medications, or sometimes they don't even need their medications. CoQ10 can be that effective in some cases. Lack of CoQ10 also weakens the immune system. Macrophage cells, which are really important. Macrophage cells are on the hunt looking for cancer cells. They kill cancer cells. They're also very important antigen-presenting cells. If you have an infection in your body, the macrophages bring the antigens back into the lymph system, and it tells the CD4 helper cells to recruit an immune attack against the infection. So as your CoQ10 drops, the macrophages are a little less intelligent, and your immune competency drops as you get older. This may account for the fact that cancer rates rise as you get older, and also a greater risk of virulent infections. So we've seen in cancer patients in some studies, giving them higher levels of CoQ10 can help to, in some cases, decrease the recurrence of the cancer once treatment has been completed. And CoQ10 deficiency is seen in Parkinson's disease. In the substantia nigra, and we'll look at this again in Parkinson's, it can't make enough CoQ10. There's not enough ATP to make dopamine. The person has tremors. The CoQ10 is also a powerful antioxidant. You get neuronal death from free radical damage, and Parkinson's proceeds. Some early studies by Clifford Schultz, a very famous neurologist, showing if you give early-stage Parkinson's patients high doses of CoQ10, you can stabilize their disease and slow the progression quite dramatically. That usually is not passed on to the Parkinson's patient, unfortunately. So making CoQ10 is a 17-step pathway. After age 20, you actually start making less CoQ10. But by about age 40 or 45, you're getting to levels that are low enough that supplementation starts to make sense. Once again, the two pathways to make CoQ10, we saw this before, down through HMG-CoA reductase and then to CoQ10. But you can also make it from the amino acid tyrosine through the secondary channel. So once again, those statin drugs block this particular pathway, so people on those drugs need to get CoQ10, 90 to 100 milligrams, even if they're not older people, even younger people who are on those drugs need CoQ10 so they don't end up with a CoQ10 deficiency and all of its consequences. There are other drugs that also decrease the nutritional status of CoQ10. Look at all the different drugs that have been shown to either decrease its synthesis or somehow block its absorption. But again, the important ones for me are beta blockers and HMG-CoA reductase inhibitors. Those ones have an effect. The sulfonylureas are ones that are used for diabetics, actually, to help get more insulin into the bloodstream. And here, look at these thiazide diuretics, may decrease CoQ10 synthesis. Antidepressant drugs may do it, the tricyclic ones like amitriptyline. So just so you've got, I wouldn't ask you to remember this entire list. That would be, I can't remember it myself. But it's just a little referral thing for you to have in clinical practice. But statin drugs, of course, are the ones that most importantly inhibit the production of CoQ10. After age 40, a lot of experts, including myself, think each person should take about 30 milligrams a day to compensate for that loss to prevent congestive heart failure. After age 60, at least 60 milligrams, I think, makes sense. At this stage in my life now, I'm 57, I actually take 3 cardio essentials a day. That gives me 90 milligrams of CoQ10 and about 125 milligrams of a standardized grade of Hawthorn, which I also want to have to maximize heart function and get the endothelial function in place. You can get CoQ10 from food. The average intake is about 5 to 10 milligrams a day. That's okay to age 40. But then to get the missing amount of CoQ10 after the age of 40, to get the 30 milligrams, you need to eat half a pound of sardines or 2.5 pounds of peanuts every day. That could give you a stomach ache. So it's not practical to get it from food after the age of 40. It's a fat-soluble antioxidant, which is important because it works around the mitochondria, it works in the membranes, it works in the fatty tissues of the brain as well as an antioxidant. It also is an immune stimulant, as we talked about, through the macrophages, and has tumor suppressor properties. In congestive heart failure, we've seen that in 75% of people that have congestive heart failure, that 75% of those people actually have a CoQ10 deficiency, and their blood levels of CoQ10 are low. When you give them enough CoQ10 to bring their blood levels back to above 3.5 micrograms per milliliter, usually a dose of somewhere between 50 to 100 milligrams 3 times a day will bring their blood levels back. You start to often see the heart pump get stronger again. I've seen some incredible cases where the person's in congestive heart failure, you give them therapeutic amounts of CoQ10, the piston's back in the engine, the heart pump gets stronger, and they start to improve their overall cardiac ejection fractions, and they're doing much better. So in North America, a lot of medical doctors are not up on the research on CoQ10. I mean, the medical doctors I know certainly know all about it, and they're spectacular in how they use it. But it's primarily used in Denmark, Italy, Sweden, Israel, and Japan. Those medical doctors there are really trained on CoQ10. A lot of North American physicians have not seen the research. The thing I love about it is that there's really no drug-nutrient interactions that are really serious, other than the one with warfarin Coumadin, but that just requires monitoring. It doesn't mean you can't use CoQ10. For high blood pressure, you're going to need 100 to 200 milligrams a day. For angina, often 100 to 200 milligrams a day. For arrhythmias, 100 to 200 milligrams a day. is usually the dosage that's used. Now, if a person has any of these problems, high blood pressure, angina, arrhythmias, they're going to be probably on medications from their physician. If you want to add CoQ10 and or Hawthorn to this mix, you need to make sure that the physician is knowledgeable about this application and has sort of granted consent to the patient, because these can be some tricky things, especially angina and arrhythmias, which are trickier minefields, of course. Hawthorn works with CoQ10. I've mentioned this to you before. It has the flavonoid compounds that actually help to increase cyclic AMP. From cyclic AMP, you make more ADP. Then from there, you make more ATP. So Hawthorn increases energy production in the heart muscle. It also dilates the blood vessels by increasing nitric oxide. Has a natural blood pressure lowering effect by acting as a calcium channel blocker and an ACE inhibitor, sort of mildly. So the person's blood pressure is high, it can help to bring it down. If it's already low, it's not going to drop it through the floor any lower. It's the leaves and the berries that contain the active flavonoid components that make this thing work so well. Again, increasing cyclic AMP. From there, you add a phosphate, you get AMP. With the help of CoQ10, you now get ATP. Clinical studies in Japan and other parts of Asia and Germany show that Hawthorn alone has been very helpful in cases of congestive heart failure, increasing the ATP production in the heart muscle, with hypertension as a natural blood pressure lowering medication or natural agent, and in cases of angina, probably via the release of nitric oxide, useful even in angina cases. The dosing, the Hawthorn should be a standardized grade of 3 to 5% flavonoid content. It's the flavonoids that are the active constituents. And normally, I like with every 30 milligrams of CoQ10 to accompany it with 37.5 milligrams of a standardized grade of Hawthorn. That's what I did in Cardio Essentials. I think that's the right combination for people. But again, you couldn't give that supplement to somebody on digitalis or digoxin, because Hawthorn and digitalis can't be used together. So the way that I use this Cardio Essentials, I put CoQ10 in there with the Hawthorn. I also added more quercetin, because quercetin decreases inflammation in the blood vessel wall, which also has an anti-vascular disease effect. So I put those three together. It's what I take. For anti-aging purposes, I take 1 capsule from age 40 to 60. After age 60, I would take 2. Person has high blood pressure, I'd give them 2 capsules 2 or 3 times a day. For angina, about the same. For congestive heart failure, you might want to take it up to 3 times a day, 2 capsules. But again, the physician would have to be in on this and in on angina, congestive heart failure, and in hypertension. If it's just essential hypertension, you can start to do these things and see how the patient's blood pressure is reacting as you monitor it yourself. And there's the contraindication. So this brings us to the final component of Lecture 1, which still relates to vascular disease, and that is the use of anticoagulant medications and agents. So warfarin is really a synthetic derivative of coumadin. So a lot of plants contain what are called coumarins. Probably familiar with this. And they can take these coumarins and they can easily convert them into the drug coumadin. So coumadin actually is sort of a plant-derived natural agent. And then they can make a synthetic derivative that they call warfarin. And they both do the same thing. They inhibit these vitamin K-dependent coagulation factors. I'm going to show you this. The idea of giving somebody warfarin or coumadin is you want to prevent the buildup of a thrombus in the artery wall in people that are high risk for that happening to them. We're going to look at who those high-risk people are. Because, of course, the thrombus can actually clog the blood vessel, or the thrombus can break off. And if the thrombus breaks off and starts to float, what do we call that? That's an embolism. And an embolism can lodge in the brain or in the lung and cause sudden death. In the lung particularly. You're having this, person can't breathe and they can die within minutes. So in high-risk people, you don't want them to form a thromboembolism. They will give them these things that are anticoagulants called coumadin or warfarin. Here's the essence of how they work. In order to make certain blood clotting factors, and we're going to look at those in just a moment. So for instance, prothrombin, which is a major stimulator for platelets to clump together. The prothrombin, in order to make prothrombin, you have to convert this inactive prozymogen into prothrombin. And to do that, you need vitamin K for the carboxylation reaction. So once the vitamin K has been used up in the reaction, then what the body normally is I have to recycle the vitamin K back to its reduced state. So there's an enzyme called the vitamin K epoxide reductase enzyme, which recycles the vitamin K back to its reduced state so it can keep participating in these carboxylation reactions, and the wheel goes round and round. And so you can keep making clotting factors. What if I were to put an agent into the body that blocks the vitamin K epoxide reductase enzyme, and now the vitamin K can't recycle, so I can't make as much prothrombin, I have fewer clotting factors, my platelets are not as sticky, so I have an anticoagulant effect. Do you follow that? So coumarin and warfarin are vitamin K epoxide reductase inhibitors. That's an exam question, for sure. I want you to understand how it works. So in the normal situation, why would platelets clot in the first place? Well, normally coagulation begins almost instantly after an injury to the blood vessel that's been damaged, or the endothelium. So like you have a small cut, you don't bleed to death, platelets come and they clump together, right? That's the normal response. And the same thing happens internally if a small blood vessel breaks or there's an injury. However, if you eat a really high animal fat diet, or you're not doing aerobic exercise, or you have a lot of body fat, or you smoke cigarettes, you increase the clotting behavior of your platelets, there's a greater chance you're going to form a thrombus and an embolism just because of faulty lifestyle behaviors. That's why so many people today are on coumarin or warfarin. The platelet adhesive index is terrible. Their platelets clump together. They got blood all clumped together. So rather than make the dietary change, the doctor just writes a prescription for coumarin, warfarin, or as we're going to see, Plavix. When the real answer for a lot of people is endurance exercise, eat less animal fat, get the weight off, and stop smoking. And all of a sudden, you have blood that actually functions normally. So there's two responses now when there's been an injury or when you're having these faulty dietary lifestyle behaviors. There's the intrinsic clotting pathway. So right inside the platelets themselves, they get excited and they start to clump together. And then there's the extrinsic pathway, which you have studied, where the liver is constantly making these sort of clotting factors. You know, remember like the Christmas factor and all, we're going to see them in a moment. And those factors are floating through the bloodstream in an inactive form. But once there's stimulation, they then, through this cascading effect, eventually will convert prothrombin into thrombin, and then thrombin converts fibrinogen into fibrin, and it meshes all the platelets together, which are already clumping anyway, and you get this thrombus formation, which I'm going to show you. So here's normal platelets sort of just floating around, minding their own business. And then here's what happens when a thrombus starts to form. You see the platelets, they've sort of adhered to each other. They've got little receptors, so they adhere to each other when they're stimulated to do so. And then you see all this stringy mesh-like material that's sort of stringing it all together? That's fibrin. That's fibrin. So the extrinsic pathway from the liver increases the production of, converts prothrombin into thrombin, and thrombin then converts fibrinogen into fibrin, and those strands are the fibrin, which now start to mesh, create a mesh where the platelets get trapped. You form a thrombus. So here's the intrinsic pathway here in the platelets. You have all these different factors. There's stimulation, and there's a cascading effect. But notice the final event is prothrombin becomes thrombin. Thrombin converts fibrinogen into fibrin, and fibrin cross-links the platelets. And at the same time, from these factors made in the liver, the extrinsic pathway, you have these other factors coming down, also converting prothrombin into thrombin, and you get the cross-linking as you make more fibrin that way. My point is that a lot of lifestyle factors actually create this effect. You don't need an injury to the blood vessel wall to do that. That eating a high-fat diet, being overweight, not enough exercise, smoking cigarettes, makes platelets clump together. That's as much a risk factor for vascular disease as high cholesterol is. And so the person says, my doctor told me my cholesterol is fine. I'm eating all these terrible foods. And then one day they wake up with a deep vein thrombosis. And they go, holy crap, This is scary, because if a piece of that breaks off and floats to your lung, you're dead. Or a woman who's taking hormone replacement therapy that increases her fibrinogen levels. Does this mean something now? Right? She now is making more fibrin, and everything else is normal. Boop, has a sudden death heart attack, has a stroke out of nowhere, has a thromboembolism out of nowhere. Why? Because the fibrin, there's more fibrinogen, it became fibrin, and it meshed all the platelets together, and she's got a serious thrombus. So these thromboembolic events are very, very serious problems. And so you see that the vitamin K dependent, these are the vitamin K dependent clotting factors that you see. Factor 9 is, vitamin K is required to make factor 9, factor 7, factor 10, and also factor 2, in addition to prothrombin. So here's the clinical application. Here's where medical doctors use coumarin and warfarin to prevent thrombosis and embolisms in certain disorders. If the person's already had a venous thrombosis, they've had a deep vein thrombosis, or they're at high risk for one, a DVT, then if you're in the hospital, they give you put you on a drip, right? You're on heparin to break the clot down. But the long-term management is you're on coumarin or warfarin to keep the platelets so they don't clump together, if you will. It's also used prophylactically and in the treatment of thromboembolic complications associated with atrial fibrillation or cardiac valve replacement. So if there's atrial fibrillation, there's going to be greater turbulence. The blood's not moving smoothly. There's more turbulence. The platelets are going to bang into each other more and start to form abnormal clots more easily. You've got to thin the blood so you don't form clots where there's atrial fibrillation. The same is true if I've got a faulty cardiac valve that's vegetative and things can stick to it more easily. Or they did a cardiac valve replacement, which is not a normal type of valve really. You're afraid that things are going to stick to the valve, and then it might break off and float to the lung and cause sudden death from an embolism. So they want to thin the blood, and that makes sense to me. Otherwise, the person's at high risk for a thromboembolic event. Or if the person's already had a stroke or after a myocardial infarction, to prevent a second one, they want to keep the blood a little thinner so that platelets don't clump together and form the final plug, leading to sudden death or possibly another stroke. In the decision making for this, it's very, very tricky. If you give the person too much coumarin or warfarin, then you make their blood so unsticky that if it needs to clot, it can't, and the person bleeds to death. Excuse me. So one of the side effects of coumarin and warfarin is sudden death from internal bleeding. So you know that if you were to use rat poison, let's say you had rats in your basement, or mice, and you can give them rat poison. Rat poison is often coumarin or warfarin at very high doses. The rat eats it because they make it taste good, and the rat bleeds to death. That's how they die. So the same thing happens to humans if the dosage is too high. So it's tricky to get it exactly right. And now if I'm a chiropractor and I'm treating somebody physically and I'm doing things to them to adjust them, and the platelets can't clot normally, and I break a couple of small blood vessels, how much does this person bleed? Whether it's subcutaneously or internal, I've got to be very, very careful as soon as I see that they're on an anticoagulant drug. Because medications can interact with those drugs, supplements can, vitamin K foods can. So what happens in the general course of this is they go onto an anticoagulant drug like this, and they're monitored very closely just on a daily basis. They're trying to get the INR just about right. So the person's bleeding time or prothrombin time has to be managed very carefully. So on blood tests, the normal INR is between 0.8 and 1.3. Standard lab tests, 0.8 to 1.3 is the normal INR on a blood reading. If the INR is below 0.8, the platelets are really sticky. If the INR is above 1.3, then I'm getting an anticoagulant effect. So for people with cardiac valve replacements and atrial fibrillations, they might move the INR up to 2.5 or even 3, really making it very unsticky. So you as a practitioner should know the person's INR because you're going to be doing things to them physically. Once they stabilize the INR at the range they want it at, then they can monitor the person, a little more periodically, if you will. So there's the reference range, 0.8 or 0.9 to 1.3. That's known as the international normal ratio. A high INR means that there's a high chance for bleeding, whereas a very low INR means there's a greater chance of clot formation. So a normal healthy person between 0.8 or 0.9 to 1.3, people on warfarin might be as high as 2 to 3 I, and that might be the target that they want for these people to make their blood less sticky. The major adverse event is fatal or non-fatal internal hemorrhage. So you have to be very, very careful with the drug itself, as well as supplements and foods that can and medications that can interfere with how the drug works. Okay, here's a slide that I want you to memorize. I know it's late in the day. But in human case reports, people have had serious bleeding adverse reactions by simply combining anticoagulant drugs, warfarin or Coumadin particularly, with garlic supplements, ginkgo biloba, ginseng, donquay or angelica species. We see some bleeding problems, the hint of it. People using cranberry extract products. Let's just go through those for a moment. A lot of people just take garlic supplements because they hear it's good for them, right? So now they're on anticoagulant. That's a bad idea. I'm not saying you're going to give these people these supplements. I'm saying through their own reading in different magazines and radio and going into different stores, they got convinced this would be a good thing for them to do. You need to be on the lookout, because on your intake questionnaire you're saying, what medications are you taking? Are you taking any supplements? You're going to ask that. You're going to write down, so you're going to go, oh my God, this person is taking garlic and they're on Coumadin? Are you crazy? Who's the person who's going to take ginkgo biloba? Who's self-medicating with that? An elderly person who read an article in a magazine that said ginkgo biloba is good for memory. Now, you know how many elderly people are already on anticoagulant drugs? Lots of them. They're in a high risk for vascular disease. Doctors give them anticoagulants all the time. And the person's taking ginkgo? They're a bleeding disorder waiting to happen. Get them off the ginkgo. Ginseng, oh, ginseng is good. It's a good tonic. It's good for my sex life and all. I have all these reasons for doing it. Good for immune function. I'm not saying it's not good for those things. It works. But if they're on an anticoagulant, man, that's a bad combination. Donquay, women going through menopause or managing PMS, sometimes will use angelica species. It works, but it's loaded with coumarins. It has an anticoagulant effect. You see a hint of internal bleeding in certain case reports. And women that have had recurrent urinary tract infections know that cranberry extract can help to block the recurrence of urinary tract infections. We'll talk about this in a later lecture. But in a person on Coumadin or warfarin, that's not such a good idea. So notice that it's just simply the 3 Gs, D and C. Remember, DC is like doctor of chiropractic, so that'll be easy for you. So garlic, ginkgo, ginseng, and then remember the DC, donquay and cranberry. And you'll be able to memorize that list very easily. There's some other natural health products that have the hint of anticoagulant effects, but there are no studies showing that these are actually dangerous, so I still will use them in safe doses. Feverfew, which is used in the management of migraine headaches, has an anticoagulant effect. I would just be careful with the dosage I'm using. White willow bark extract, I have that in our product called Nature's Relief, but you know, white willow bark extract doesn't have the anticoagulant effects that aspirin has. It's been shown not to be such a powerful anticoagulant. I would just say, just be aware of it. Curcumin also has anticoagulant effects. It's an anti-inflammatory that's natural that you can be using. If the person's on Coumadin or warfarin, just make sure you're not upsetting the INR. Essential fatty acids, borage seed, flaxseed, fish oil, making more prostaglandin series 3 decreases platelet stickiness. Are you amplifying the effects of Coumadin or warfarin? To me, not to a substantial degree, but again, the person has to have their INR monitored to make sure you're not upsetting the balance. Vitamin E up to 400 IUs a day is not an anticoagulant. Over 400 IUs a day studies show it may have anticoagulant behavior. Just want you to be aware of that. Bromelain enzymes increase fibrinolysis, so it breaks down clots and may help to have an anticoagulant effect, may compound the effect of Coumadin. Same with papin enzymes, which are also proteolytic. So all these things potentially could interfere with Coumadin or warfarin. If the person's on Coumadin or warfarin, I put them on any supplements, I insist they see their doctor for the first couple of weeks and get the INR track very carefully to make sure something I did is not changing the INR that's going on in their body, because the doctor knows what the INR should be for that person based on the health problem that they have. So these are things that antagonize the effects of coumadin or warfarin. CoQ10, because it mimics, it looks a lot like vitamin K. We think in some people it can contribute to those carboxylation reactions and help the body keep making clotting factors when, even though vitamin K has been inhibited, CoQ10 may be able to substitute for it. So there's some hint that in the odd person, CoQ10 will actually start to bring the INR back down again. So if you're going to give CoQ10 to someone on coumadin or warfarin, the INR has to be monitored. Ginseng does weird things. It either amplifies the effects or it'll speed up the detoxification of warfarin in the liver, so that will decrease its effectiveness. St. John's wort, people will take that for mood elevation. They're clinically depressed or they feel a little bit down, they take St. John's wort, but it speeds up detoxification of many drugs and supplements. And grapefruit juice, which contains naranginine, which is a flavonoid, also speeds up detoxification of many drugs, including warfarin, in the liver. So you tell the person, don't have grapefruit juice, especially if they're on any medication. That's very good advice. There are foods that contain a lot of vitamin K. So if I'm trying to get an anti-vitamin K effect and the person starts eating foods that are loaded with vitamin K, it may supersede the effect of me blocking those enzymes. So people on coumadin or warfarin are told not to eat foods that are very rich in vitamin K, or to be judicious in how they ingest them. Kale, spinach, turnip greens, collards, Swiss chard, parsley, mustard greens. These are all very healthy foods for you and me. But for someone on coumadin or warfarin, they'd have to use maybe just one of these a day and no more. And then there's this lifestyle coaching thing, where I've had patients who have had a deep vein thrombosis or some previous, thromboembolic event, and I say, I'm going to help you lose the weight. We're going to change the fats in your diet from saturated, trans fats, fried foods, because those fats are increasing, particularly factor VII, which is a major clotting feature of all of these things. We're going to get you doing the right amount of endurance exercise, so we help to thin your blood in a more natural way. If they're cigarette smokers, of course, they have to quit. We're going to give them borage seed, flaxseed, and fish oil to help make more prostaglandin series 3, which is going to make the blood a little less sticky. And I have actually seen with a couple of patients who had deep vein thrombosis problems previously, they were told they're going to have to be on coumadin or warfarin for the rest of their life. With just the coaching program I just showed you, slowly over time, the doctors lowered, they said, the INR, boy, your INR is really good. I can use less coumadin. They said, they get to the point, they say, you know what, you don't even need coumadin anymore. You're perfectly in the INR range that I want you in, and you don't need any coumadin. How are you doing this? The guy says, I changed my diet. I'm doing 30 minutes of power walking 5 times a week. I'm taking some vitamin E supplement. I'm taking a combination of essential fatty acids, fish, flaxseed, and borage seed from this capsule. I'm taking 2 or 3 a day. I've lost some weight. Doctor says, you know what? Your INR is exactly where I want you to be. You don't have to be on the drug. And I like that because the drug, is such a narrow index of safety. The person can have internal bleeding at any time, that I'd rather have them not be on the drug and just follow the game plan here. So that can be done concurrently even if the person is on the drug. You can change what's called the hemostatic dynamics of the blood, the clotting behavior of the blood, and the perfusion of the blood through lifestyle change and some just gentle supplements like vitamin E and essential fatty acids. The last drug in this category of anticoagulants, which is gaining tremendous momentum, is Plavix. So you see the commercials on television about Plavix. The person has the platelets are clumping together and forming this narrowing of the artery, and then the Plavix and the platelets get released and they float through the bloodstream and you open up the clogged area. Have you seen this commercial on television for Plavix? It airs all the time. So what Plavix is doing is it blocks receptors on the platelets so they can't clump together so easily in the very first place. So it's blocking some of the intrinsic pathway, decreasing aggregation and sort of cross-linking by fibrin. But in 1 in 2,000 cases, Plavix can cause severe neutropenia. So let's just revisit the white blood cell differential. Of all the white blood cells in your bloodstream right now, up to 40 or 50 or 60% of them at least are neutrophils. Neutrophils are one of the most important white blood cells you have. Why is that? If they see any kind of microorganism, they can sort of cozy up next to it and they can release what's called a respiratory burst of hydrogen peroxide, and they can blow it up. They can nestle up against the cancer cell, and they can literally blow it up with hydrogen peroxide. Neutrophils can also, through phagocytosis, ingest the microorganism, or they can ingest the cancer cell and also destroy it in other ways. So having any kind of drop in your neutrophil count is not a good thing. Also, the incidence of hemorrhage may be increased through co-administration of aspirin. So if you take aspirin in conjunction with Plavix, very bad idea, great high risk of gastrointestinal hemorrhage, which is not a great thing, and possibly cerebral hemorrhage, but to a lesser degree. So the use of non-steroidal anti-inflammatory drugs is discouraged in those taking Plavix due to increased risk of digestive tract hemorrhage. So it's very important the person doesn't take aspirin in conjunction with Plavix, which people would be, a person gets a headache, they reach for an aspirin. They forget, oh, I'm on Plavix. Plavix is the second top selling drug in the world. It came from, no one's ever heard of it, to the second leading prescription drug in the world is now Plavix. Doctors are convinced that people are walking around with sticky blood and we need to thin the blood, and Plavix is the perfect solution. Whereas the real solution is exercise, less fat, lose the weight, stop smoking. But that's not the advice. The advice is write the prescription, give them Plavix. So in 2005, they had sales of almost $6 billion a year. As we wind down now, this is the last slide, what I want you to know is that the same supplements that potentiate the effects of warfarin also potentiate the anticoagulant effects of Plavix, and also COX inhibitors or cyclooxygenase inhibitors such as aspirin, ibuprofen, Voltaren. It's the same precautions. That means this: if the person's on Plavix, warfarin, or Coumadin, they have an anticoagulant effect using the mechanisms I've shown you. You can also add to the anticoagulant effect when you give people non-steroidal anti-inflammatory drugs like aspirin, entrophin, Voltaren, which is diclofenac, ibuprofen, naproxen, indomethacin, Celebrex. I'm bringing these drugs to your attention because you're going to see patients that have pain and inflammation. There's a very good chance most of the patients you see are going to be on at least one of these drugs: Voltaren, indomethacin, different types of aspirin, Advil, Motrin. You see them up here. And so those drugs, because they inhibit the cyclooxygenase enzyme, are blocking the synthesis of prostaglandin series 2 in the platelets. So the platelet now is making less thromboxane. The platelet is now already, the platelet is now having an anticoagulant effect just because they're taking an anti-inflammatory drug. So anti-inflammatory drugs like this also have anti-clotting behavior. That's why combining Plavix with aspirin increases the risk of hemorrhage. What I want you to know is that when you combine supplements that also block these effects, you can take supplements that also have anticoagulant effects that are powerful, even with these types of medications, then you start to increase the risk of bleeding as well. This is why garlic and ginseng and ginkgo and dong quai and cranberry extract, they have to be very, very careful with those kinds of things. If the person is on a non-steroidal anti-inflammatory drug, if they're on Plavix, or if they're on Coumadin or warfarin. However, if the person's on one of these cyclooxygenase inhibitors or they're on Plavix, they can eat vitamin K containing foods. That's not going to be a contraindication in terms of dietary factors that would interfere with the effect of those drugs, only with Coumadin or warfarin. So that'd be a good exam question, wouldn't it? You know, can you have vitamin K containing foods if you're on Plavix, Voltaren, indomethacin, or is that going to mess up the anticoagulant effect? Perfectly fine to do. It's only with Coumadin or warfarin because they're inhibiting the vitamin K epoxide reductase enzyme affecting the vitamin K pathway. So on that note, we covered a lot of territory. Thank you very much for staying with me. You now know a heck of a lot about vascular disease. I'll see you in a few weeks and we'll cover a whole bunch of other health conditions. Thanks very much, everybody.